bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
All right, hello everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to be talking about PICU-Liberate, the ABCs of recovery. It's my pleasure to welcome a team of presenters from the McMaster Children's Hospital in Hamilton, Ontario, who are going to tell us about their journey to improve the experience and outcomes of those children who have had a stay in the PICU, the Pediatric Intensive Care Unit. We've had amazing advances over the years, and particularly in critical care medicine, but there's lots of consequences and comorbidities associated with a stay in the PICU. So we're not now just going to be talking about improving survival, but improving that quality of survival is one of the ways that our team has put it. So it's my pleasure to introduce the team from McMaster. In fact, I'm actually just going to introduce the lead of the team, and Dr. Karen, who is Dr. Karen Chung, and she's going to introduce the rest of her team. But Dr. Karen Chung is a pediatric intensivist in the PICU at McMaster Children's Hospital, and she's also a professor in the departments of pediatrics, critical care, and health research methods, evidence, and impact at the McMaster University. Dr. Chung's current program of research focuses on morbidity prevention and early rehabilitation in critically ill children, and her desire to improve outcomes for pediatric survivors of critical illness has led to the implementation of the PICU-Liberate toolkit at McMaster Children's Hospital's PICU. So it's my pleasure to hand the virtual podium over to Dr. Karen Chung.
Thank you very much, Doug. Good morning, everybody. I'm just going to try and make sure that we can show our screen here. And good morning. Thank you very much for that kind invitation. Because you can't see all of us here, I'm going to start by introducing the rest of the panel members. Sorry, guys, just trying to change our slides here. So Doug has already introduced me.
Hi, I'm Dr. Cynthia Cupido. I'm an associate professor in the Department of Pediatrics and Critical Care at McMaster University.
Hi, I'm Philomena, and I'm the quality and safety nurse here at the Children's Hospital.
Hi, I'm Ashley Todd, and I'm Nathan's mom, who is a patient in the PICU at McMaster.
We're just going to start with a couple of disclosures. Our PICU-Liber8 study is funded by the AFP Innovation Grant out of the McMaster and London Health Sciences. Restorative Therapies has provided us with equipment that is the cyclogometer for our research, and the patient images that we're going to show you are with their consent. First of all, for those of you who don't know where we are, McMaster Children's Hospital is in Hamilton, Ontario, Canada. We're one of a total of 5 academic PICUs in Ontario. Our PICU is a busy 12-bed medical surgical unit with an annual admission rate of 850 patients per year, and we service a population base of more than 2.6 million. What we'd like to focus on for this webinar today is to give you an understanding of what's happening to critically ill children and to tell you about PICU-acquired complications. I'm going to talk to you about PICU-Liber8, which is an early rehabilitation bundle of practices that we've implemented in our PICU to prevent these PICU-acquired complications and promote recovery in critically ill children. In the next 40 minutes or so, we're going to focus on specific elements of the PICU-Liber8 bundle and key implementation strategies that have worked for us in our center that you may want to consider for your patients and or your PICU. And perhaps this might be important information for you if you're a patient or family member. At the end of our formal presentation, we'll turn over to Doug and Grace to show you a brief video that we made on how these elements tie together. Finally, we'd like to end by hearing your stories, challenges, and successes, and how we may collaborate to redefine and improve our care of critically ill children. What is pediatric critical care all about? When people think about PICU, they think about resuscitation and saving lives. PICU is very front-end focused, and we're trained to recognize problems early and address the vital ABCs, meaning the airway, breathing, and circulation that is the core of resuscitation and PICU practice. As soon as we have stabilized our patients and it's clear that they're going to survive, we start our discharge planning to make room for the next sick child, because this is a high turnover specialty and there are high demands for our PICU beds. We have, in the last 20 years, got very good at resuscitation and stabilization. Advancements in technology and our ability to deliver care has improved significantly, such that the mortality rates amongst critically ill children has decreased from 11%, where it was 20 years ago, to an all-time low today of 3%. However, the population being admitted into our PICUs today has changed. Because of advances in life support and our ability to treat different diseases and the improving survival of the extreme low birth weight premature infant, the children coming into our PICUs today are sicker and more complex than before. Up to 68% of children admitted to our PICUs in Canada today have a chronic medical condition, and a third of these patients have severe disabilities. As a result, our PICU admission rates have increased and are triple what they were 10 years ago. The growth in children with complex medical conditions now far exceeds the number of available PICU beds. And so there's a lot of focus on survival in critical care. In contrast, we're just beginning to understand that survival is only the beginning for many critically ill children and their families. Because the majority of these children do survive, because the increase in complexity of children being admitted to our PICUs today and the emergence of these PICU-acquired complications that I'll describe later, we're starting to see the emergence of problems that affect function and quality of life of children and their families that can persist long after they're discharged from the PICU and return home. These problems are known collectively as the post-intensive care syndrome. This is well recognized to affect critically ill adults. What is less known is that this also affects children and infants. I'm now going to turn over to Ashley to tell you about her story and Nathan's journey through our PICU. She's first and foremost a parent of a critically ill patient, but she shares a unique experience because she also was a PICU nurse in our unit before.
Thank you, Karen.
Sorry. We're just going to reboot there was a problem with our PowerPoint. We're just going to reboot that again. Apologies. Okay, can people see our slides again?
Actually, we're now looking at the wrong monitor. If you could switch.
Okay, just swapping that over. Can you see us now?
That's perfect. Yep.
Okay, great. Thank you. Sorry about that.
Thank you, Karen. When my son Nathan was 3 months old, he was admitted to the PICU at McMaster Children's with bronchiolitis and pneumonia. He was weak, exhausted, and could not breathe by himself. He needed a ventilator or breathing machine to help him breathe. This was an incredibly stressful time for Nathan and for us, but I thought I knew what to expect because I was a former PICU nurse and had cared for many babies just like Nathan. Little did I know that the most difficult part of our journey was still to come. Nathan required assistance from the ventilator for about 2 weeks. After 15 long days in the PICU, we received the happy news that all was stable with Nathan and we were ready for discharge to the ward. My husband, my daughter Hannah, and I were thrilled. We thought the worst is behind us. Nathan's PICU team told us he was doing great and that he would be feeding and home in a couple days. We were relieved and ecstatic. However, I knew that Nathan was not back to his usual self just yet. Just prior to leaving the PICU, I noticed that he was jittery, unsettled, and seemed unable to root. I was told that this was withdrawal from the sedative infusions that he needed while he was on the ventilator. I was told that this was common and would not last long. Nathan also seemed really weak. He had lost a lot of weight while he was in the PICU. We were worried, but everyone reassured us that this was to be expected and it was typical considering what Nathan had been through. This is Nathan on the ward. He seemed sad, he was not smiling, he was disengaged, and he wasn't interacting with me or my husband, nor was he interested in his toys. He was weak, and he was really floppy and needed his head supported like he was a newborn again. This was a huge change from before his admission. He couldn't even do basic things like latch. Attempting to reestablish breastfeeding was all-consuming and exhausting for both him and I. Trying to feed took all of his energy, and Nathan couldn't feed enough orally, so he had to be tube-fed for almost an entire month. This video is one of Nathan on the ward 10 days after leaving the PICU. He may look appropriate if you didn't know him, but he's not himself. His movements are jerky, he has a dazed appearance, he's easily startled, and he was often inconsolable. I kept expressing my concerns to the medical team and they reassured me that his withdrawal was temporary, but they couldn't tell me how long it would last. They managed his withdrawal with more medications, which made things even more complicated. He was either jittery and unsettled or too drowsy and uncoordinated. Watching Nathan suffer through withdrawal, who was either often inconsolable or drowsy, was like torture for my husband and I. I felt terrible for Nathan and frustrated because I felt like I should have known how to recognize these problems and deal with them, but in fact I had little experience recognizing and managing prolonged withdrawal after the ICU. On one particularly bad day, I saw another family I knew from the PICU and we had a talk. They told me that the withdrawal was the worst part. I have to say that I agree with them. Watching my baby go through withdrawal was the most horrific part of his illness, something I wouldn't wish on anyone. This got me thinking, did all families that leave the PICU endure these additional dark days? Looking back from when I worked there, I never really appreciated what families went through after they leave. This was a very difficult time for our whole family. Hannah was sick too, and I wasn't there for her like I should have been. It was also Christmas time, and instead of planning a special first Christmas as a complete family, we were hoping we would be able to get home and get back to normal. We spent a total of 30 days in hospital before finally being discharged home. We had spent just as many days outside the PICU on the ward as we did in the ICU when he was critically ill. Unfortunately, Nathan's recovery was far from over even after returning home. The effects from his time in PICU were still evident. You can see in these pictures, Nathan is pale, expressionless, and he looks sad. We are lucky to have the help of an occupational therapist to help rebuild his motor strength to try to regain his lost milestones. We worked on reestablishing basic things like head control, trunk strength, and rolling. We have now achieved good head control and improved trunk strength, but we're still working on rolling. Feeding was still a nightmare. I struggled for 2 more weeks at home trying to reestablish breastfeeding. This was stressful not just for Nathan, but it became difficult for Hannah, my almost 3-year-old daughter who developed separation anxiety. I ultimately had to stop breastfeeding and turn to formula. We are now 2 months after our original PICU admission, and Nathan's journey to recovery is ongoing. I still notice a big difference compared to other babies his age in both his development and his stamina. I'm really grateful to the PICU for caring for Nathan and saving his life. While Nathan no longer has pneumonia, his recovery is far from over. However, there were amazing aspects of the Liberate model that were incorporated into his care that helped his post-PICU recovery. I truly believe that without Liberate, Nathan's recovery could have been even more complicated. McMaster is doing incredible work with Liberate that is helping children thrive after their critical illness and get back to their childhood.
Thank you, Ashley, for sharing your and Nathan's story. It was really brave of you to go through these details again, and I know that parts of your story is still hard and emotional for you to describe. So what does Nathan's story illustrate? Unfortunately, his story is not unique. What we now know that what Nathan experienced is not uncommon. But what is not recognized is that Nathan's symptoms were not all withdrawal. The medical team did not recognize that Nathan was actually suffering from delirium, and so the approach to his management by giving him more drugs perpetuated his symptoms. Nathan also experienced ICU-acquired weakness. Clinicians don't believe or recognize that infants and young children can develop these problems and therefore don't screen for them routinely. These problems not only impacted on Nathan, but on his family and his sister. These problems persisted even long after he returned home. Nathan's story and others like his are what inspired PICULiber8, because we need to not just focus on saving lives in critical care, we need to think about how we can bring rehabilitation into the PICU to create a healing environment within the intensive care setting to help these families recover. So what are PICU complications? These are morbidities that develop as a consequence of interventions in the PICU. The specific PICU-acquired complications that I'm referring to are delirium, sleep disturbances, withdrawal, and ICU-acquired weakness. I want to emphasize that these are unintentional problems that arise as a result of the care that we provide despite our best intentions because of the nature of our patient population. I call these new, but really they've always been there. We're just starting to recognize them. These problems have emerged over time because of the common paradigm that critically ill children should remain immobilized in bed when they're ill, and mechanically ventilated children should be sedated for safety reasons. Excessive sedation is therefore very common in PICUs and leads to iatrogenic withdrawal. Sedation is also a major risk factor for delirium and ICU-acquired weakness. Bedrest and immobility in turn is a risk factor for delirium. These problems are therefore interrelated and common. What we now know is that PICU-acquired complications is very common and affects 61% of children. So why do we need to think about rehabilitation within the PICU? It's because it's common. You can see that the incidence of sedation, PICU-acquired weakness, and delirium has doubled and even tripled in some instances in the last 10 years. These have direct impact on short-term outcomes such as mechanical ventilation, length of stay, and even mortality of our patients in some instances. Perhaps more importantly, these problems affect outcomes that are important to patients and families. We now know that 82% of children suffer functional disability and 93% of children have a decline in their quality of life after critical illness. This is much higher than reported 10 years ago. Why should we care about PICU-acquired complications? That is because they're strongly associated with an increased length of PICU and hospital stay, and they're associated with poor functional outcome. As most of our critically ill children survive, PICU-acquired complications rather than mortality is a more important marker and appropriate marker of the quality of our care. We should care about PICU-acquired complications because they're modifiable, and preventing them may decrease the length of stay by as much as 9 days and improve functional outcomes. Decreasing these complications may also affect and improve parental stress as well as recovery. I've described to you that oversedation, withdrawal, immobility, and delirium are interrelated. Therefore, single-pronged interventions may not be the most effective approaches to reducing these complications. Rather than providing different solutions to the same problem, evidence demonstrates that addressing these problems collectively through a bundle of complementary interventions enhances uptake and promotes multidisciplinary team collaboration. We now know through our research that key targets for improvement that we can modify in order to make an impact on PICU-acquired complications are to reduce sedation, prevent prolonged immobilization, and also do whatever we can to involve families and reduce their parental stress. The goal of PICULiber8 is not just to improve survival, but survivorship. In critical care, we need to learn to focus not just on early recognition for resuscitation, but on early recognition for rehabilitation. Our responsibility is not just to save lives, but save lives with better quality. PICULiber8 is a pediatric-specific bundle of complementary practices. It consists of these 8 components here modeled after the Adult Society of Critical Care Medicine Liberation Initiative. We expanded this bundle to include G for good nutrition and H for humanism. Humanism and family engagement are vital components because the main objective of PICULiber8 is to understand the patient as a person, provide patient-centered care that can impact on outcomes. We're going to do an overview of a few specific PICULiber8 bundles. I'm now going to hand over to Dr. Cynthia Capito, who's now going to talk about the ABCD components of PICULiber8.
Thanks, Karen, for that excellent background. So, recognizing the importance of withdrawal and delirium as significant ICU-acquired conditions, in 2015, the Canadian ICU Collaborative and Canadian Patient Safety Institute led a national improvement initiative to address pain, agitation, and delirium management in the ICU. We at McMaster were fortunate enough to participate in this Pad Your ICU initiative, which provided a valuable forum for interprofessional critical care practitioners from across the country to share our ideas and strategies. In the next several slides, I will speak to how we went about padding our PICU at McMaster. While our PAD working group was led by a steering committee, we recognized that in order to be successful, we would need engagement from our entire unit. So we established our dream team, a dedicated group of eager interprofessional PICU staff members who volunteered extensive amounts of time to participate. We encouraged members to self-select the PAD-associated projects that they were most interested in, and we created subgroups to have ownership over those projects. Our subgroups were given 4 overarching goals in developing our PAD bundle: to develop analgesia and sedation strategies to avoid over-sedation, to create routine screening for withdrawal and delirium, and to develop an approach for management, to implement strategies to optimize non-pharmacologic management of pain, agitation, and delirium, and to ensure engagement of family members as key stakeholders in their child's care. We recognize that this would be an iterative process, and so we built in an ongoing process for feedback and revision using PDSA principles. We adhered to fairly tight timelines. We joined the PAD Collaborative in the fall of 2015. By early 2016, we had already recruited our PICU working group. We completed development of our clinical and educational resources by June 2016 and initiated education of our unit with an email blitz in July and then one-to-one education of bedside caregivers and learners in August. With that timeline, we were able to go live with our Pad Your ICU bundle in September of 2016. To facilitate the Pad Our PICU bundle, we created a number of clinical resources. First, we created a new sedation and analgesia algorithm, which introduced a new tiered approach to pain and sedation management, with Tier 1 using an intermittent dosing strategy, Tier 2 constant infusions, and Tier 3 the addition of adjunctive medical therapy over and above those infusions. The algorithm encourages starting at Tier 1 and ramping up only if pain and sedation targets are not being met as judged by a patient's pain and comfort scores. The algorithm also does allow for a rapid wrap-up approach to Tier 2 or Tier 3 for certain patients to achieve the goals of therapy. To complement the algorithm, we also created a new sedation and analgesia order set for ventilated patients. And again, we embedded that same tiered approach into the order set, along with routine assessments of patients' pain and comfort scores. And with that, we noticed that people started to speak the same language around pain and sedation management. It became part of our day-to-day culture to have bedside discussions about what tier of sedation a patient required, whether we were meeting pain and sedation targets, or if a patient needed to move from one tier to another based on their pain and comfort scores. Having the pain and comfort scores routinely assessed also helped to support decision-making based on objective patient data rather than an individual clinician's preference. It also facilitated allowing patients to be more awake while being ventilated as long as they were comfortable. And then this in turn helped with other components of our Liberate bundle, such as early mobilization and humanism. Recognizing that withdrawal and delirium are both affected by our approach to weaning of sedation and analgesia, we also created a new opioid and benzodiazepine tapering algorithm to help guide our clinician group with their weaning strategy. The algorithm routinizes the use of the WAT1 and the CAP-D scores to screen for withdrawal and delirium and to encourage a goal-directed wean. It also highlights the importance of a non-pharmacologic approach in the management of delirium. To encourage sustainability of the PAD initiative, we created a number of bedside and electronic charting tools to support the ABCDs of our Liberate bundle. We amended our daily goals checklist to identify if a patient was on PAD alert and to direct care according to our pain, sedation, and weaning algorithms. We also implemented a routine delirium screening tool using the CAP-D scoring system to help identify delirium. And we created the clever mnemonic, I'm a person, to make it easier for our bedside clinicians to identify and eliminate risk factors for delirium with a non-pharmacologic approach. Finally, and perhaps of greatest impact, we focused on modifying our PICU environment to prevent delirium. Anyone who's ever walked into an ICU knows how loud it can be. And so great efforts were taken to reduce noise in patient rooms. We used earplugs for patients when needed. We made an effort to keep patient doors closed. We downloaded decibel meter apps on our smartphones and installed a Jabra noise meter in the middle of the PICU as a constant reminder to keep noise levels down. We also encouraged day-night orientation in the PICU by creating a PICU lighting policy to support lights on during the day and out at night. We implemented a PICU bedtime routine with quiet hours between 10 at night and 6 in the morning. And we adjusted the timing of routine care to make it more patient and family-centered rather than physician-centered. For example, we worked with our radiology department to move routine morning x-rays from 6 o'clock in the morning to 8 o'clock in the morning. All of these changes have helped us to promote a clustered care approach for our patients in the PICU. Patients have their own daily care schedules that are personalized and they're patient and family driven. They describe wake-up times, nap times, and bedtime routines. And they also allow us to schedule routine care, such as bathing, playtime, and importantly, mobilization. So with that, I'm going to hand back to Karen, who will describe our approach to early mobilization in the PICU.
Thank you, Cynthia. So why early mobilization? I've listed here a list of top 10 reasons. The first reason is that bed rest is bad for you. You know that PICU-acquired weakness is common and affects up to 30% of children and even babies like Nathan. The perceived barriers to mobilization are modifiable. We now have pediatric-specific data telling us that early mobilization is feasible and safe. Mobilization promotes sleep, and it actually improves F, which is family engagement. Through adult evidence, we know that early mobilization promotes reduction in sedation and delirium and improves ICU outcomes. It also improves post-ICU outcomes such as function and neurocognitive recovery. It is also cost-effective. We now know that prolonged bed rest continues to be a problem in critically ill children. In our multi-site Canadian study, we found that less than half the patients receive physiotherapy or occupational therapy while they're in the PICU. And the commonest form of rehab is chest physiotherapy, which has not actually been shown to improve patient outcomes. We know that mobilization is delayed. Early mobilization occurs in only 9.5% of patients. The main barriers to mobilization are as follows. Physicians admit that they're uncomfortable and lack the knowledge to mobilize children. There are lack of resources and dedicated physiotherapists in many of our PICUs. And there are institutional barriers, such as the need for physician order and lack of guidelines. Physicians are not the first clinician to recognize patient readiness for mobilization, yet we still insist that a physician order is required. So how do we implement early mobilization in our unit? First, we partnered with experts in the field to develop these practice recommendations for early mobilization published in the Journal of Pediatric Intensive Care last year. Our key messages are that mobilization cannot occur in isolation. It requires teamwork and it needs to be supported by a PAD bundle. Patients need to be able to wake up and comply with mobilization where possible. It needs to be goal-oriented and individualized, and mobilization needs to be safe. In terms of making mobilization and exercise-based rehab goal-oriented, it needs to be age-appropriate. So we recognize that neurodevelopmental play is a form of mobility therapy in children. Also, we know that kids will be kids, and if they're not interested, they just won't participate. So we need to be engaging. This is a video of coupling humanism with early mobilization as we use pet therapy to encourage this child to mobilize. We pull together these guidelines and use a traffic light system, as safety is paramount. Each day, we ask 3 questions for every patient. Is it safe to move, i.e., are there contraindications or precautions for mobilization in that patient? What is the individualized goal, and how can we make it happen? We made physiotherapy part of the daily care plan, and mobilization is scheduled into every day. By doing this, we found, firstly, that there were fewer and fewer contraindications as physicians became more comfortable, and as we gathered more safety data. And 2, we found that planning mobility activities in the day gave patients and families something to look forward to in the day. The other aspect of implementing mobilization, we said that we required in the past a physician order. We revamped our PICU admission order set so that there is an automatic physiotherapy consult because they're the experts on mobility therapy. We made activity as tolerated our default. Any activity order other than that required completion of a physical activity order set. In this activity order set, you can see that we removed bedrest as an entry. This allowed us to have dialogue between particularly the subspecialty services like surgery to clearly communicate what was allowed or not allowed in their patients. We ensured that early mobilization was part of our daily goals checklist, which Phil will talk to you about later. And we came up with educational tools and encouraged early mobilization champions. Here are some of our mobility champions. Remember that mobility in children requires creativity, and we all play a role, including child life. In terms of champions, we found that families were our best ambassadors and advocates because they really endorse exercise-based therapy and rehabilitation. Cynthia and I presented some of the details of our key PICU-Liber8 components. This early rehabilitation initiative would not be possible without key stakeholder engagement and nursing leadership. I'm now going to hand over to Phil, our quality and safety nurse specialist, to present to you how we pulled all of this together to make PICU-Liber8 a culture of practice within our PICU.
All right, thank you very much, Karen. So I'm going to walk through how we used all of this evidence presented today and translate it into practice. I found this great quote by Michael Margolis that summarizes how he changed culture to make the Liberate bundle become a new standard of care. And it says, if you want to learn about a culture, listen to the stories. And if you want to change that culture, then change the stories. And that's exactly what we set out to do. Here's a schematic of the comprehensive 8-part Liberate bundle. On the right-hand side, you'll see the collaborative multidisciplinary team that is needed to bring the bundle to life. Adoption of this bundle will require large-scale change and will take time. To implement the new care bundle, we used the Structure, Process, Outcome framework by Donabedian. By strengthening our structure and redesigning our processes, we hope to achieve the outcome, which was liberate care for every patient every day. Our structure started with creating a collaborative core team. Much time was spent planning and evaluating the current state in our unit. We identified what we were doing well and where our biggest practice gaps were. We wanted to start with some quick wins, so we chose to focus on bundle components where we already had some structure in place. And we decided to start with A, B, C, D, as Cynthia spoke to. We then created subgroups to engage frontline staff in the planning and ownership of specific bundle components. Here is a picture of our delirium prevention group. As we highlighted, bundle algorithms were created, and then to create more deliberate practice and make it easier for staff to provide bundled care, once the algorithms were tested, they were then converted to order sets. And similarly, once paper scoring sheets for delirium were finalized, scoring was then created within our electronic documentation system. Our team had already adopted using a daily goals checklist on rounds for every patient every day. This checklist was a trigger to ensure goals were set and interventions were evaluated every day. We reconfigured this tool to help guide liberation goal planning. The checklist went through many iterations as each new bundle component was launched or revised. We next incorporated liberation prompts into our morning huddle. Every morning, our team meets for 10 minutes to review safety concerns and plans for the day. The huddle was adapted to also include liberate goals and identify which patients were ready to liberate, who was ready to mobilize, and who was on pad watch or pad precautions. Staff education was a huge undertaking. Work group members taught the applicable bundle components in small groups. This peer-to-peer training helped create local champions. We also ensured new staff were taught as part of their onboarding education, and medical learners received liberate orientation prior to their rotation in the unit. Bedside liberation binders were created, and information was updated as each component was launched and revised. Poster boards were hung in our staff room to provide additional information about the bundles. We took advantage of any avenue to share, including hanging updates in our staff bathroom. Weekly newsletters were used to share Liberate updates with staff. We also partnered with families to capture Liberate experiences and share them on social media. Here are some tweets, one celebrating our staff starting their night with Liberate care, and secondly from a family sharing their experience with PICU-Liber8. So processes were changing in the unit to support humanism. Nightlights were installed, play mats and developmental toys arrived, name cards were added to all of the patient rooms, and liberation goals were being posted on patient whiteboards. Now, evaluation was important as many change cycles were happening. We used staff surveys and feedback from families to help guide our next steps. We then decided to share our clinical innovation beyond our PICU. We shared across our institution of Hamilton Health Sciences, and then during Nursing Week, we used that opportunity to share our experience with our local newspaper. Even though PICU-Liber8 was still evolving, we decided to share our journey nationally. As we went to share, we also listened and learned from our audiences. This only motivated us to continue developing PICU-Liber8. So this brings us to our outcomes to date. We set out to change PICU care and culture by changing the stories. Despite this journey taking many years of small iterative changes, we are thankful to our patients, families, and staff. They have inspired us to continue on this journey to create a new narrative in the care of critically ill children. And we thought we would show you a few pages from our story. So you can see here how humanizing the environment has become our norm. And here families are engaging in early activity with their ventilated baby. Here the staff is making playtime a priority, and it's even hard to notice that this patient is on a ventilator as he's up on his rocking horse. And here awake patients are able to communicate with their healthcare team and enjoy activities that they normally would enjoy if they were at home. Here the child's playing Connect 4 with our child life stuff. And then this little guy is up and ready to meet his activity goals for the day. So we are now going to hand over to Doug and Grace to share a video that captures Liber8 in action, and then we will open the webinar to questions.
Thank you very much. That's the end of our presentation, and we welcome any questions or comments, stories that you may share with us.
All right, thank you very much. I mean, great presentation, great way to end with that video. It's a fantastic video, and that is available on Vimeo for anyone who does want that. I believe the link is on the Knowledge Exchange Network if that's something that you want to share with your colleagues who weren't able to attend today. It's certainly a great intro to what they were doing at McMaster Children's. And I especially want to thank Ashley for sharing her story. Dr. Chung sort of mentioned how important it is to hear from families and how difficult it is sometimes, but certainly want to make sure that we thank Ashley for sharing that, because it really grounds everything we do. Hearing that, taking all these things from a patient-centered approach, it really helps to hear from the families to make sure that we really understand whether we're hitting the mark on some of these things that we are presenting and trying to do in the healthcare system. So as Dr. Chung mentioned, any questions that you do have, please type them into the question box. We do have some coming in. The first question was, a couple questions were actually related to sort of what were the barriers to implementing. You had lots of pictures of the whole team, everybody smiles on their faces. It looked so simple and easy when you did it. You did mention in the one slide about one of the challenges was around physicians' comfort level with mobilizing certain patients, or lack of knowledge of what kind of mobilization was important, and the need to engage the physiotherapists more fully in the process. But what were some of the other potential sort of barriers, whether they be organizational culture or professional interdisciplinary issues or that sort of thing? What were some of the barriers that someone could expect when trying to implement this?
Yeah, it's Karen here, and perhaps I can start by answering that question. We felt that there were definitely barriers. We decided to formally study it, and so we sent out surveys to multiple PICUs across Canada, and we actually did an observational study to see if what people were telling us was actually true. The number one barrier was probably practice paradigm consistently, because a lot of physicians, particularly physicians, felt that it was unsafe to move a child that was critically ill, and that would cause more stability. So that the first barrier was a mindset. And so in order to overcome that, we had to start with some research, extrapolating, first of all, research from adults, but also gathering some pediatric specific data, our own data, as well as data from other researchers, to start to educate clinicians as well as nurses that it was actually possible, feasible, and ultimately safe. We then set an example. So it required a couple of champions in our unit. Our first response was always, "Are you kidding me? You want to do what?" But through a lot of education, patience, also substantiating it with evidence, we were able to start to change culture. And as I said, this didn't take overnight. This took years of long, hard work from the ground level. And what I can say, reflecting back on the experience, is that the original naysayers are now our champions. It kind of drives itself now. We have nursing champions, and really the families really endorse it, such that they're asking for this now. They're advocating for their own patients. And so we've been able to see the fruits of this after multiple years of hard work.
It's Cynthia here. Maybe I can talk about some practical barriers that we experienced as we embarked on the PAD bundle. So, for example, when we created our new analgesia and sedation algorithm and order set, we wanted to be able to include novel medical therapies for our PICU, such as dexmedetomidine, only to find out that it wasn't on our hospital's formulary. And so we had to go through formal steps to have Precedex added to the formulary, and that took some considerable time and effort from our ICU pharmacist. When we decided to embark on the Lights Out campaign to support sleep hygiene, we couldn't figure out why in the middle of the night the TVs were always on in each of the patient's room. And it was only until we spoke with parents that we found out that our PICU rooms were not equipped with night lights. And so TVs were being turned on in the middle of the night to provide some low-level lighting for the patient's room, which then led to us being able to get night lights and have TVs turned off. And then there was definitely a challenge with learners, and there continues to be a challenge with learners who irregularly rotate through the PICU. So in the PICU environment, we're constantly faced with new participants on the healthcare team. And so what we did was established a method of orientation for each and every trainee prior to them starting in the PICU to get oriented to the PAD bundle and to the Liberate bundle prior to starting their clinical work.
It's Philomena. I would say the other thing is definitely at the beginning people thought that this was a crazy idea, but I think that the stories actually help validate that we could safely move patients. And so we used momentum. Even the first time we had a patient sit on the horse for his day therapy, it went over so well. So we were felt that much more comfortable to try it again with the next patient. And I think the structure changes really helped try to standardize the approach so that it would be across all of the intensivists, but definitely, ups and downs with the whole process.
Thank you for that. Those answers. I mean, a great sort of overview of it and some nice specific examples of what you were able to do to sort of help overcome some of those barriers. So thanks for that. One of the questions that came in from Amy, she was just asking, what other non-pharmacological pain management techniques did you find effective?
So it's Cynthia here again. So we really wanted to engage behavioral therapies. So our child life specialist, Stephanie, was paramount in helping to engage children at the bedside. In unique circumstances, we engaged alternate therapies, including massage therapy and acupuncture therapy.
Yes, and I think actually even having our pet therapy was a great welcome for children. And we're fortunate to have a full-time child life in our unit. And we couldn't do this without having someone dedicated to help kind of bridge the gap like that for especially non-pharmacological and therapeutic play.
Mm-hmm. One thing I wanted to add, Doug, is that particularly in the intubated ventilated patient where they can't articulate or communicate, our previous paradigm was to assume that they were uncomfortable, that any movements or interpretation of heart rate or blood pressure changes was an assumption that they were in pain or discomfort, which led to a vicious cycle of increasing administration of drugs and so on and so forth. So after introducing the PAD bundle and educating clinicians about formal assessments for pain and other things that might lead to discomfort, such as delirium, and the introduction of tiered sedation, and the principle of safely allowing them to awaken, is that we were able to stop some of these vicious cycles that were oftentimes actually delirium, allowing these patients to wake up, express themselves, and communicate in a safe way. Was actually taught us that not all of these impressions were actually due to patient discomfort per se. And so that also was started out with the anecdotes, and just like the mobility movement, once we could lead by example and show other clinicians that it was safe and that it was actually okay, and not distressing to children to actually be awake and ventilated, we were able to educate them that not everything is actually pain or discomfort while they're ventilated.
The other thing that was successful was, and although it's acute mnemonic, the I'm a person, it actually was quite functional in helping us to address the uncomfortable patient. And as Karen suggested, being able to address other problems outside of pain that we may feel is associated with being intubated and ventilated. So for example, by applying the I'm a person mnemonic, one might find out that a patient's bladder is full and not emptying properly, that a patient is constipated. And when those problems are relieved, all of a sudden the patient's comfortable again, the vital signs stabilize, and we're able to wean back on previous dosing of medications.
All right. So we've got a question here from our friends at Montreal Children's Hospital. They say they're working hard there to do something similar, and they're excited to see the potential that you've inspired. One of the things, and you sort of have mentioned some of these things in the previous question about sort of the barriers to implementation, and even some of the things you were just talking about. But they're asking about they're having ongoing challenges in getting 100% compliance with the sedation and pain assessments. Do you have any tips for how you sort of overcame that last few percent and got to 100% compliance with the sedation and pain assessments? Anything in addition to what you've already mentioned, or if there's anything specific you'd like to, repeat in that area?
Yeah, I think it's Cynthia again. I think that's an excellent question. We cannot overstate how engaged each and every member of our PICU team has become. And so we rely on each other really to police ourselves. And it's been a constant PDSA cycle. This is not something that we achieved over the past 6 months or even the past over the past year. This has taken a couple of years to implement and to achieve. And I think continued encouragement, ongoing education blitzes through email and one-to-one education.
Yeah, I think it's definitely ongoing. I don't think we are there 100% in compliance either, but we recognize that, and so then have put in measures to, like we had said, onboarding of staff, having them have an orientation, and we are still educating. I think education will never end because of just the turnover of staff we have in the PICU.
Mm-hmm. One of the strategies was the daily goals checklist. Before, the daily goals checklist was very clinically based. So by embedding PICU-Liber8 goals within the daily goals checklist, it grounds people in things that are actually shown by evidence to actually improve outcomes. The important thing that makes the daily goals checklist functional is that it's not isolated to the physician. It needs to be completed by the team. And so it encourages a dialogue between either the physician trainees and or fellows and or attendings to talk with the nurses or physiotherapists or respiratory therapists, etc., in order to complete their checklist. The checklist is not just compliance-based. It's also linked to an implementation, an impression, and a goal. So that is one ongoing tool where we try and encourage a team discussion on how to optimize compliance with some of these PICU-Liber8 bundles.
And related to that, what we haven't talked about yet is engaging the most invested stakeholders, and that's the patient and the family. And so we really have created a welcome environment in the PICU to have families present for our bedside rounds and to have families' participation in the bedside checklist. It's okay for a family to speak up and say, what was my child's CAP-D score today? And I think by engaging patients and family, that's helped enormously.
All right. We did have a couple questions about the resources required to implement. Specifically, you mentioned the child life specialist, and so we've got some people asking, did that require any additional child life specialist time or support or positions, or was that just incorporated into an existing role? Similarly, for the physiotherapist that you said you were engaging more, did that require more physiotherapy resources than you had already had? And do you have any kind of scale, a measurement of physio resources per bed or child life specialist per bed that you had to add in your ICU?
I guess we're fortunate to already have that structure in place. So we currently do have a dedicated physiotherapist in the 12-bed unit. We have a 0.6 position that's an occupational therapist and the full-time physio. So we didn't have to ramp up any of those resources. We already had them. The only additional resource we had was the quality nurse that worked Monday through Friday, who really was the continuity between all of the team members. But other than that, we were fortunate to already have those resources.
It's Karen here. I just can't overemphasize the engagement of nursing leadership in this. because I think, physicians can come up with some ideas and some may be good or not, but without the nursing management and the ability and the luxury of having the quality and safety nurse, none of this would have happened. We didn't have additional resources, but we tapped into the resources that were already available. For example, mobility therapy doesn't have to be instituted by physiotherapists alone. So educating, empowering nurses, allowing them to do the screening, and engaging families. So some of the pictures that we showed you are actually showed you that once we schedule it in the day, the family's all full on. The nurses work together with the families in order to mobilize the patients. And what we've seen over time is what we don't have is after hours physiotherapy coverage. So PICULiber8 continues on the weekends. It can only continue on the weekends if the nurses and the family members and the respiratory therapists are also engaged.
It really certainly speaks to the team element that you were able to demonstrate and talk about, and particularly demonstrated in the pictures. I mean, it really seemed like the team is all on board with this, so that's great. We did have a question from Armando, who is asking about implementing the need or the potential role for the PICU-Liber8 bundles outside of sort of the large academic PICU. So for example, implemented in mixed type ICU beds for hospitals that don't necessarily have like a full PICU. Is there a role for that in our community sort of hospital PICUs or mixed type ICU beds?
We've actually been discussing here about really Liber8 should be not isolated to the PICU. And we started out with Ashley's story showing you that, trying to illustrate that really the information needs to roll out to other locations outside of the ICU, whether it's a non-academic ICU to actually the pediatric ward, because the rehabilitation doesn't stop once they leave the PICU. It needs to continue. So Ashley, do you have any comments about that?
So Nathan has inspired me as the educator of the medicine floor to take some of the amazing components of Liber8, and we want to extend it beyond the ICU past into our ward care, because we know that the ICU recovery doesn't end when they're discharged, that it continues while they're on the ward and then even when they go home. So we want to be part of the Liber8 story and improve our care on the wards.
All right, we are just a couple minutes over time. We have two more questions that we're going to try and get through before we wrap up, and hopefully our panelists are able to stay with us for just a couple more minutes. Maria is saying that she noticed in some of the pictures that there were restraints on some of the children. So she's asking, when there's no staff member or family member around, if the patient is agitated, is the patient agitated in restraints and therefore re-restrained again until the next time someone can be with him or her? And in the end, how much time do they spend restrained and sedated versus awake and mobile? Was there an opportunity to reduce restraint usage and that sort of thing with the implementation of this bundle?
It's Philomena. That's a great question. Our unit was already using restraints, and it's definitely an opportunity now that we've gained increased comfort with having kids awake and being able to care for them safely, is looking at our use of restraints. They're not used on every patient. It kind of depends on the developmental age of the child, the engagement of the family. Anytime we use them, it's in collaboration with the family, and we try to use them as minimally as possible. But I think moving forward, it's again that paradigm shift that kids don't need to be sedated and have their hands restrained. So it's definitely still an opportunity for us to look at minimizing the use of restraints.
Question we have, and after this question, we'll hand it back over to you, Dr. Chung, for any last closing key messages or thoughts that you'd like to leave the audience with before we wrap up, and I'll leave it to you to engage the rest of your team there if they have any comments they'd like to make as well. But the last question is coming from Paula, and she's just asking about accidental extubations with the increased mobility or early mobility. Has there been any increase in that, or did you notice any change in the number of accidental extubations?
Mm-hmm. So we were able to formally track this, and actually we did this we studied our early mobilization practice guidelines in a clinical trial and found that there were no increased adverse events, including accidental extubations with mobilization. What I will say is that there are probably just as many or more adverse events with non-mobilization, keeping patients in bed and doing things like chest physiotherapy. So we've been able to use that safety data to encourage and inspire this movement. And that's consistent with the adult literature and other researchers as well, who found that mobilization and allowing patients to be awake is actually safe and appropriate. So perhaps in closing it, and this has been a great experience for us to share our story with you, and the questions have been great. The one thing perhaps I will leave you with is that this is not something that's isolated to our unit. We'd love to learn from other units, and we're still trying to educate ourselves as we move forward, because this is a dynamic issue. And so I encourage you to continue sharing your stories and your questions with us so that we can continue improving on survivorship after critical illness in children.
All right, and I think that's a great place to wrap this up. It's such a great presentation, some great tools, a great quality improvement approach, and using data to sort of track your progress and family engagement and everything. I mean, really a great program. So congratulations to the team for such great work. All right, like I said, with that, we'll wrap this up. And just to mention, we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's great when you can watch live, as your questions and comments really enrich the discussion, as you can see here. But when you can't watch live, the recordings are made available after the fact on the Knowledge Exchange Network at ken.cafc.org. That's ken.cafc.org. Our next webinar on February 28th is going to be about critical incident stress management, contributing to a healthy workplace. This session will feature our colleagues from the Alberta Children's Hospital in Calgary, where they'll discuss their program to help address the symptoms of PTSD, moral distress, compassion fatigue, and burnout that we recognize as being far too common in the acute care setting. The development of their critical incident stress management program is to support staff with managing the heavy load of complex, ethically challenging, and potentially traumatic cases, such as non-accidental trauma, organ donation, unanticipated deaths, resuscitations, and end-of-life care, etc. So that'll be an interesting presentation for those of you from the PICU world who participated today. And following that, on March 7th, we're once again going to hear from CAFC's very own community of practice in children's pain. And this time we're going to be talking about pediatric chronic pain and introducing you to the CAFC Chronic Pain Toolkit using a case study. And during that, we'll have experts from across the country, our leaders from our community of practice, talking about what is chronic pain, the most common types of chronic pains, signs and symptoms. As a primary clinician, what can you do for chronic pain for your patients? How do you refer, or how to refer to chronic pain clinics? And chronic pain impacting families, and what resources are there available for families of children that are suffering from chronic pain? So some really useful tools and information coming up on that one on March 7th, sorry. So some great stuff, as you can see, coming up in the next couple of weeks. Thanks again to our presenters and our team from McMaster Children's Hospital, and thanks to all of you for joining us today, and hopefully we will see you back here next week. Hi, everyone.
Bye. Thank you very much.